Good morning, everyone. So this is Charlie Fensel, and I'm doing this final iteration of the podcast on February 18th. I'm in my apartment right now overlooking beautiful West Philadelphia, and I'm excited to talk about the concept. So the concept is health-related quality of life, and specifically how it relates to brain tumor patients. And I feel like this is a vastly important concept because for decades we've talked mostly about quantity of life in brain tumor care and very little on quality of life in brain tumor care. And why in particular I feel it's important for brain tumor patients is that the length of survival for most brain tumors is relatively short, that the most common brain tumors are very aggressive. In fact, the most common brain tumors overall survival from diagnosis is about 14 months. So I feel like it's very important for when people think about what care they want and how they want their lives really to be structured after a diagnosis that we can talk in an informed way about the quality of life in these patients, and not just how long will this specific treatment extend your life or what the side effects are, but really how other people's lives were affected by the disease in these treatments outside of just the standard talk. And so let's kind of get into health-related quality of life. So what is health-related quality of life? Well, in fact, there is no unified agreed upon definition. McDowell in 2006 did a large review of quality of life and could not find any substantiated agreed upon definition. And so just as a working definition for the remainder of this podcast, health-related quality of life really is a construct that tries to capture overall someone's social well-being, their psychological well-being, their physical well-being, and it can even be multiple other components depending on the specific measurement being used. So I've been using the word measurement because really how I want to break down the topic of health-related quality of life is dissecting one or two measurements and comparing them to each other. So let's kind of get into that. So the history. Really, health-related quality of life has changed a great deal over the last several decades. As you can see in the table right here, is that these are three of the most commonly used proxies or actual measurements of health-related quality of life. So you can see really that there's big differences between the reliability, the validity between these results, and I'm going to talk a little bit about two in particular. So the first is the Karnofsky Performance Scale. So the Karnofsky Performance Scale was actually first made in 1940, and it was made at the advent of when chemotherapy was really coming out. And so Dr. Karnofsky made this score in order to really judge someone's ability to get up and interact with the world and kind of what a caregiver's responsibility would be for this person. And it was largely subjective, and it was supposed to measure the soft parameters of quality of life for a patient. And the idea of how it could measure quality of life is that the inference was that, performance scores, or the ability for someone to really physically function in the world, largely would dictate their quality of life. However, in the 1980s, Greco and Long found this to be wildly untrue, that while this KPS score was pretty good at capturing certain domains, in general it was a very poor single global index. And this really called upon the need to have a better health-related quality of life measurement. And with the KPS, you can see a few other problems, is that one, it was physician delivered, and so the patient wasn't even able to really express their quality of life. And as we all know, quality of life is very subjective and comes from the person themselves. And then in the 1990s was really the first released measurement for health-related quality of life, specifically as it pertained to brain tumors. And this was part of the functional assessment of cancer therapy, and it was created by Weitzer and colleagues in 1995. So really the construct of how this measurement was made was based on this general scoring system that had been created in the 1980s. And it was this really beautifully created health-related quality of life that try to capture these things I had previously mentioned: physical well-being, social relationships, emotional well-being, and all these other components. And from this general score, Weitzer took a very different trajectory from the KPS and really focused on the patient and the caregiver's perspective. Really, it went to the fact that the authors constructed this quality of life measure based on patients and what they were saying to them. So they did a large study where they interviewed both patients and caregivers, and they got large transcripts that they then brought to an expert panel. And from that expert panel, they synthesized these questions, and then from the synthesized questions, brought it back to the patients and said, does this really reflect what you believe is affecting your quality of life? Is this really what you think your quality of life is summarized as? I think this was beautifully important because it really purported a strong construct validity, and two, I think it really involved patients and the ability to say, yes, this is what we think is important. This is really what quality of life means to us and this specific population. So at the same time that this study was being done is that they had done a lot of other validity studies. In fact, they had done a depression scale and the KPS scale as well as a few other scales, and they found that there was a lot of concurrent and construct validity related to this scale, that as depression went up, that they were seeing that their overall number for the quality of life was going down. And they saw that there was relationship between the KPS, even if it wasn't a perfect agreement. So they were really able to show that there was strong validity here. As well as that, they were able to show that there was high reliability. They did retest in their population and find that there was a significant correlation. And in fact, over time, many people have replicated this study in different populations, actually, of brain tumor patients. So the first population used was primary brain tumors, which really means that they had tumors that just started in the brain. However, this same measurement has been shown in tumors that come, say, from the lung or other parts of the body, and has been kind of taken through the same process of really assessing, do patients feel like this is an accurate assessment of quality of life, and then comparing it to multiple other measurements to see, is this a valid measure, as well as the reliability tests previously mentioned. So as you can see, there's this really big difference between the overall quality of life measure that the FACT-BR really represented and what the KPS really represented as a performance proxy. And so the evolution of health-related quality of life has really been vast, is that it's gone from a performance score given by a physician to now a self-administered questionnaire that people are really able to identify, these are the problems in my life, this is what's affecting my health-related quality of life. And as you can see from the table I previously mentioned, that the FACT-BR, in my opinion, is one of the gold standards of health-related quality of life, and that it is extremely reliable. It's been put through the ringer for validity, and I think it really does a great job of capturing different components of quality of life. And in general, I think if more and more often these things are used, that we'll be able to have more informed discussions about what actually is happening to someone as they go through this process of diagnosis and treatment. So I want to thank you for listening to this podcast, and I hope that you have a wonderful rest of your day.